Next up, Dr. Lisa Christopher Stein will provide a clinical overview of adult dermatomyositis. Dr. Christopher Stein is a professor of medicine and neurology at Johns Hopkins and director of the Johns Hopkins Myositis Precision Center of Excellence.
This, as you know, is a rare autoimmune disease. It's debilitating. There are systemic autoimmune symptoms, and it's not just muscles or skin. We do know, however, that it does cause muscle inflammation that damages the muscle tissue, and of course, a variety of other organs are also affected. This usually affects adults between the ages of 40 to 60, peaking at middle age around 50. We know, too, that about a third or so of kids, of those who have juvenile onset dermatomyositis, can transition into the adult form. Women are more affected than men in general, about 3 to 1, and that's consistent with what we see in many autoimmune diseases where women are preferentially affected. There are distinct features, and they can range from quite mild to very debilitating, quite severe. What we suspect is that dermatomyositis prevalence is somewhere between close to 2 and 21 per 100,000 of the population. Mortality is something that fortunately we don't have to face all of the time, but it is a reality for some of our patients. If you look at the best population studies that compared death rates in 326 patients diagnosed between 2003 and 2012, the mortality ratio for dermatomyositis itself was about 2.6 compared with that general population. Another study suggests that the overall mortality in the inflammatory myopathies is highest during that first year after diagnosis, and then fortunately decreases, whereas mortality in the general population actually increases over that 10-year subsequent period. When we look at death in myositis, the main three focuses there are on malignancy, cardiovascular disease, and lung disease, like interstitial lung disease. Dermatomyositis is thought to develop as an interaction between genetic and environmental risk factors. And as a clinician who sees a lot of these patients, I am struck by the fact that I have myself cared for identical twin sets of patients, and none of any of the identical twin sets of patients I care for, in both do they have the disease. So this is discordant, meaning only one twin is affected. So it is not all genes, but perhaps it's also not all environment either. It seems to be a difficult and complex interplay between the two. We know that both adaptive and innate immune mechanisms and non-immune mechanisms are at play here. Within the muscle tissue, whether it is actually the myocyte, the muscle cell itself, the blood vessel, and or the connective tissue that's directly targeted by the immune system is up for debate. For example, in dermatomyositis, many of us in the field believe that the blood vessel is likely the initial target within the muscle, and those myocytes become innocent bystanders that then become affected by inflammation themselves. Plasmacytoid dendritic cells, these are potent sources of interferon, may also be found surrounding intermediate-sized blood vessels that are located around those cells in the paramecium. And we know that type 1 interferon-inducible genes are among those that are most upregulated in the muscle, the skin, and even the peripheral blood of patients with dermatomyositis. Very briefly, looking under the microscope, if we look at the top images, we see to the left, this is what a normal muscle looks like in cross-section. They're all about the same shape and size and fiber, and around the periphery, we see the nuclei of the cells. So in a normal muscle cell, nuclei are on the periphery. They don't come to the center. To the right, I think you can appreciate that this is an area of inflammation here in our slide, where there are lymphocytes are coming to invade and surrounding normal muscle cells. This is more histologically consistent with polymyositis. Dermatomyositis, on the other hand, those same cells first target the blood vessel. And then we see something here, which is called perifascicular atrophy, in which we see that the cells that get close to each other, the myocytes, lose some of their volume as they come to the interface between two fascicles of the muscle cells. What's probably one of the most prominent in different studies, between 20 to 40% of our patients have evidence of pulmonary disease. And this is usually in the form of interstitial lung disease. There are specific immunologic targets, certain self proteins that really predict that pulmonary disease will be more common. The peripheral vascular system itself with Raynaud's phenomenon, these are color changes to times of stress or cold. And again, certain autoantibodies a little more common in those. But in addition to the muscles, the joints are also affected. And many of our patients actually present with an arthritis, so much so that some of them come in with the diagnosis of rheumatoid arthritis erroneously before the other cardinal manifestations of the disease take hold. Myocarditis is sometimes seen and can be an incredibly difficult risk associated with mortality. And then cancer risk. And again, specific autoantibodies are associated with cancer. There can be some dysphagia or difficulty swallowing, and then a slew of dermatologic rashes, all of which I've touched upon. So what are the subtypes of dermatomyositis? Classic dermatomyositis, that's the one we know the best. This is hallmark symptoms, muscle weakness and skin rashes. Amyopathic dermatomyositis, no muscle weakness. And this is very important because in many patients, the skin and the muscle is decoupled. In some cases, it's hypomyopathic, where the skin dominates and is severe and debilitating, but yet the muscle itself is relatively untouched immunologically. That is not the cardinal feature of the disease. Then there's clinically amyopathic dermatomyositis, where they meet all the criteria diagnostically for dermatomyositis, again, have little to no muscle weakness over an extended period. Generally, that's usually about the first 2 years. If we don't see this in the first 2 years, they tend not to develop it. And this group is distinctly at risk for developing interstitial lung disease. And then finally, that associated with interstitial lung disease itself, and we've talked about the fact that this can be a complication. Fatigue and fever can happen. Fever is more rare. Fatigue is very widespread. It's one of the number one things that our patients really stress is important. They can have difficulty keeping food down, have anorexia and reflux. And I've mentioned the other features previously. Patients often experience disease flares. 83% of them in one of our studies showed that there was exacerbation of muscle weakness. This is not new to autoimmune disease in general. Fatigue and exhaustion is one of the cardinal features of many of our systemic autoimmune diseases. Patients report pain. I was taught in medical school, this was a painless disease, but my patients taught me differently. And pain and discomfort in over 60% of our patients. Difficulty with stair climbing, standing up from a chair, and then skin rashes or skin ulcers, as we've already mentioned. And what is that impact? It's enormous. So 72% of our patients will have one or more of these flares per year. This is associated with more disability, more pain. You can imagine how difficult it is to maintain a normal work schedule when you do not know when your next flare will be. And increased healthcare visits.